Lesson is about the electrical conduction system of the heart. The heart is a pump that circulates blood throughout your body. Blood is a transport vehicle for a lot of things, including oxygen, which your tissues need to survive. Once the tissues have used up that oxygen, it's sent back to your heart through your inferior and superior vena cava and ends up in your right atrium. From there, that blood is forced down into your right ventricle, up through your pulmonary valve, to your lungs, where it's oxygenated, and then dumped back into your left atrium. From there, it's forced down into your left ventricle, and then up into your aortic valve, and out through your arterial system to reperfuse those tissues. Now this happens, the heart pumps in two phases. You've got phase one, your atrial contraction, which your right and left atrium contract and force that blood down to your lower chambers. And then phase two is ventricular contraction, which contracts the right and left ventricles and forces blood, like we said, to your lungs to be reperfused, and the left ventricle forces oxygenated blood out to your body. Now there is a slight delay between phase one and phase two, and that's to allow for time for ventricular refill. The electrical conduction system is what makes the heart pump in this specific sequence that makes it the most efficient pump. So let's learn about the electrical conduction system and how it makes this happen. Pacemaker cells are what make up the electrical conduction system. And you can see in yellow that that's the electrical conduction system. It spans from the top of the heart all the way to the bottom. And it is, think of it like a series of electrical wires that carry an electrical impulse across the heart to make that muscle tissue contract in a specific sequence. The way that the electrical conduction system makes this electrical signal is by pacemaker cells. So I'm just going to give you a quick example of pacemaker cells by focusing on this little cluster of cells up here. I'm just going to draw some cells all in a cluster just to give you an example of what that's like. Now, these pacemaker cells in this cluster at the top of the heart, which is called the SA node, those pacemaker cells have what's called an action potential. Let's just draw this negative action potential of these cells. And you can also graph this, looks something like that, where these cells have a continuous inflow of sodium and also calcium. And rushing out of these cells is potassium. And this exchange in electrolytes causes the cells to depolarize. So this cell is depolarizing. That's what we refer to that when that action potential is realized. It's depolarization. So that cell then is in contact with this cell and this cell and this cell, and that depolarization spreads throughout those cells, causing this cascade, kind of like a domino effect that spreads. It starts here and it spreads across the atria, and it causes those tissues to depolarize and contract. Now, you also have these cardiac myocytes, which are cells just located in the heart that also will depolarize, but they're not constantly building towards a state of depolarization like those pacemaker cells. Their action potentials look more like this, where they're essentially not doing anything until these pacemaker cells, I'm just going to draw some regular cardiac myocytes out here. They're not doing anything until these pacemaker cells initiate electrical depolarization and then spreads from cell to cell to cell, and so on across the heart. Now, all these cells that depolarize also have to repolarize. Otherwise, they can't depolarize again. So within these cells, you have sodium-potassium pumps that are constantly pushing sodium back out and pushing potassium back in. And the end result then is that these cells go back to a state where they can depolarize once again. It's called repolarization. So depolarization is creating that electrical impulse that spreads across that tissue, and repolarization is when those cells go back to normal. Now, you don't have to understand the pacemaker cells and their action potentials to interpret heart rhythms. However, one important thing to take from this is that these electrolytes and their balances are very important when you're understanding arrhythmias. So this is the lesson here, is the importance of electrolytes and how those balances can affect your heart. Now we're going to talk about the actual names of the structures of the electrical conduction system. So we mentioned in the last slide that this is the SA node, and the SA node is the primary pacemaker of the heart. It is what in a normal heart, it is the primary pacemaker. It causes your heart to beat, and it spreads that electrical impulse, like we said, across the atria, causing atrial contraction. Now, this structure down here, this is referred to as the AV node. The AV node is also another cluster of cells. And the AV node, it causes a slight delay in that electrical impulse traveling through it. The reason for that delay is to allow time for adequate ventricular refill. So as the atria is contracting, forcing blood into those lower chambers, that delay is allowing time for that to happen. Now, that electrical impulse travels down through what's called the bundle of His, down through your right and your left bundle branches. And this is posterior fascicle, anterior fascicle of the left side of the bundle branches. The bundle branches, they have a very important job. The bundle branches spread that electrical impulse through your ventricles rapidly and evenly because you want the ventricular contraction to happen quickly, and you want both sides to contract at the same time. And of course, these are these little stems off of your bundle branches. Those are Purkinje fibers. All right, so that's what the heart does when it spreads that electrical impulse across the heart. Now, the lead placement on an EKG interprets that data, and it prints that out on an EKG for analysis. Now, you put leads on a patient. When you're doing an EKG, you've got leads all over. You've got limb leads, right? We'll just draw some down here for their legs. You've got precordial leads. You've got V1, V2, V3, V4, V5, V6. And on an EKG, those are put in very specific locations. Now, what these leads are doing, what these electrodes are doing, is they are sensing that electrical activity, and they can tell whether it's traveling towards them or away from them, and what that magnitude is, how much intensity is that. So I'm just going to use one lead here, and I'm just going to say that it's V4, for example. So it's sitting somewhere around here. And I'm going to draw an isoelectric line So anything that that lead sees as traveling towards it is going to register positively, and anything that it sees as negative is going to be anything going away from it. So when the SA node initiates atrial depolarization and that spreads across that atrial tissue, is it traveling towards or away from V4? It's traveling towards it, right? Which is going to create a positive deflection on that EKG tracing. And then when there's a slight delay through the AV node that we said, right? So there's a slight delay here, followed by that electrical impulse is going to spread across the ventricles, also traveling towards V4, creating a positive deflection. And then we said that everything that depolarizes, those cells have to also repolarize. And we see that as another positive deflection. And the important thing to understand about this is that how those deflections, why they look the way they look, and also lead placement is important. Because if I were to take this V4 lead and I were to move it up here, well then that would invert everything that I just did. So on an EKG or even telemetry, when putting those patches on, it's important to put them in specific locations so that you can get an accurate picture. Okay, this is the waveform that we just drew. It represents one heartbeat and the electrical conduction of the heart. Now we're going to name these structures. When the SA node initiates depolarization and it spreads that across the atria and it causes atrial contraction, that is registered as a positive deflection, which we call a P wave. That's the little arc that we see in blue or in green there. And then that electrical impulse travels through the AV node down through the bundle branches, right, depolarizing the ventricles rapidly and evenly. And this is represented in red down below. And there's actually three waves that we might see. You've got the Q, the R, and the S wave. Now we just call that the QRS, and that represents ventricular depolarization. And then everything that depolarizes also has to repolarize, and we call that the T wave in blue. So the P wave represents atrial depolarization and also contraction. The QRS represents ventricular depolarization and ventricular contraction. And the T wave represents repolarization, specifically ventricular repolarization. Okay, so the EKG cart takes that wave that it measured, right? And it takes that impulse, that electrical impulse, and it puts it over graphing paper. And this is what we see here. We see this is an example of EKG graphing paper. Now, each one of these boxes represents a value up and down and left and right. Now, going up and down, these little boxes represent, each one of these little boxes represents 0.1 millivolts. And within each large box, you have 5 small boxes. So one large box up and down represents 0.5 millivolts. Left and right, it's a measurement of time. Each small box, going left and right, represents 0.04 seconds. and each large box has 5 small boxes in it, which represents 0.20 seconds. And this allows us to measure the heart rhythm and all of these complexes and how long it takes for this electrical conduction system to occur in the heart. The first measurement we do is called a PR, and it's measured from the beginning of the P wave to the beginning of the QRS. Now, I know it says PR, and that might sound confusing. You'd think you'd start measuring it to the beginning of the R wave, but the truth is not everybody has a Q wave. Not everybody has a visible Q wave, so it's just commonly called the PR. And normal value for the PR is 0.12 to 0.20 seconds. That's what's considered normal. And what that's measuring is that electrical conduction system, or that passage of electrical impulse through the AV node, that delay we talked about that allows time for adequate ventricular refill. So what you're seeing is like say this is your patient at 8 o'clock in the morning, and they have a PR of say 0.15, and then later their PR looks like this, for example. And we'll say this is 0.25. So that's what we're measuring the delay through the AV node, and if it's occurred within an appropriate range or not. So 0.12 to 0.20 is considered normal. The next measurement we do is the QRS. And the QRS is measured from the beginning of the Q to the end of the S. And normal value for that is 0.06 to 0.10. That's what's considered normal. So the QRS represents what? It represents ventricular depolarization, right? And what structure is responsible for rapid and even depolarization of the ventricles? The bundle branches. So what we're measuring is how long did it take for that impulse to spread through the ventricles and cause that depolarization. And that's largely dependent on the bundle branches and how well they function. Another measurement we do is the QT. The QT is measured from the beginning of the QRS to the end of the T wave. And normal values for that are usually expected to be 0.36 to 0.44, and that is measuring the time it takes for the ventricles to depolarize and then repolarize. Now, when there is a problem with the bundle branches, it can delay that ventricular depolarization. And when we talk about delays, we're talking about the complex is wider than it was before. So let's say your patient has a relatively narrow QRS like that. We'll say that this is maybe 0.08, something like that. And then they develop a block in their bundle branches or some kind of delay. Well, on the EKG tracing, you would look for how many seconds is the QRS in duration. And it's commonly also talked about as being narrow or wide. So if we had let's say we have a right bundle branch block or a delay in the right conduction system. Well, because these are just cells, right? You've got a chain of cells that are carrying this electrical conduction system, this depolarization from one to the next, to the next, to the next, to the next. And this cascade happens all the way down. But what happens if one of those cells is damaged or it can't transmit that electrical impulse? Well then, let's say that occurs here. Well then that electrical impulse can't travel down the rest of that right bundle. And it's going to take time for those electrical impulses from the other parts of the heart to spread over to that right side. And it's going to cause a delay. So when the QRS is greater than 0.10 seconds, we can generally call that intraventricular conduction delay, or IVCD. That's a nonspecific way to say that that electrical conduction system was delayed. We're not saying why, we're not saying right or left or anything. We're just saying that it's wide and we're not sure why. Now, a very specific way to label it would be calling it a bundle branch block, specifically right or left, or maybe it's just one of the fascicles. So if maybe it's not the whole bundle branch itself, maybe it's just a section of the bundle branch. Maybe here's the anterior fascicle that this specific, this section here, all of a sudden that electrical impulse is blocked there because of damage to those cells. And then it can't get to the rest of this. Now, a cardiologist will look at an EKG, and based on what that showed, he or she would label that as a bundle branch block, right or left, or a fascicular block, depending on what they saw. Classic signs of a right bundle branch block are what we call bunny ears in V1. And then on V6, you have bunny ears in that lead for a left bundle branch block. That's the standard for that. Okay, how do we measure this? How do we measure how fast your heart's beating with this, using this graphing paper? Well, there's a couple of ways. You've got the 300 method, which is a really good way to look at a heart rhythm and quickly see how fast it is. What you do is you take 300 and you divide it by the number of large boxes between R to Rs. So here's an R wave and here's an R wave, and we're counting the number of large boxes between each one. So if I were to come over here and count this, I would say I have 1, 2, 3, 4, 5 large boxes between R to Rs. So 300 divided by 5 equals 60. So that's 60 beats per minute, just by looking at it and doing some quick math in my head. And this is a good way to tell what a heart rhythm is, just by looking at it. There's another thing that people do. People use the 6-second method, and this is more of an average, and you have to have exactly 6 seconds in your strip, which is 30 large boxes. So if you count out 30 of these large boxes, then you would know you had a 6-second strip. A lot of EKG strips will have little marks on there indicating that it's a 6-second section. And what you can do is you can count the number of heartbeats in that 6-second strip. So if this is a 6-second strip, I would say I've got 1, 2, 3, 4, 5, 6 heartbeats in that 6-second strip, which if I multiply that by 10 gives me 60 beats per minute. And that's more of an average, and that can be used if a patient is in atrial fibrillation, which we'll talk about in other lessons, or just a really irregular heart rate. That can be a good way to get an average of their heart. But the 300 method is more accurate, and it's a preferred way to determine heart rate.